Small Global Health Initiative. And on behalf of our President and Director, former Congressman Lee Hamilton, it's a thrill for us to be able to continue a series of meetings. I think this is the fourth one that we have done on health population development with a special emphasis on fragility and rebuilding states. And obviously, as you folks at AID adjust the terminology, we will adapt as well. But the issues are the same, right? And certainly remain important and vexing and challenging, but really the focus of what you folks are working on. And so we will try, as we have for quite a while now, I think 11 years, with the very generous support of the Office of Population and Reproductive Health, to try to facilitate these kinds of practical dialogues between the worlds of scholarship and research and the worlds of practice and policy. So we're thrilled, and we were thrilled here about a month ago when we saw and came across this new RAND book entitled Securing Health, Lessons from Nation-Building Missions. And we approached two of the editors who we have with us today, Seth Jones and Ross Anthony, to come share with us some of the insights from their book and their volume. And I think it's one that is rich in insight and certainly tackles some of these problems in countries that all of you are working on a day-to-day basis. I want to say one word just so that those of you who may be coming to the series for the first time, or you've just come to a few, we do have a way, even though this series is really for AID and the CAs under the Bureau of Global Health, we have a password-protected website that has, among other things, summaries of the sessions, the PowerPoint slides from the sessions, and also the video from the sessions. And in the handout that you should have picked up out there, there are the directions for doing that. Please let us know if you have any difficulty with that, if you have any suggestions for additional materials that we can put on that site to make it useful for you, things that you're trying to look for, even if it's not a particular publication, but a particular topic that we can track down and get on there. We're looking to try to be as helpful as possible to all you folks as you work through these issues. So I'm going to turn the floor over to, I think, Ross Anthony first, whom I will introduce now, Associate Director, Center for Domestic and International Health Security at the RAND Corporation. Someone, as you can see from the bio, has had extensive experience, including within AID, but also now serving as Commissioner of the President's Task Force to improve health care delivery for our nation's veterans. And I think this is the value of, illustrative of this book, that it has folks coming from both the health side and the security side. So Seth Jones, who's a political scientist, is someone who specializes and focuses on nation-building operations and really the hard security set of questions, something he's also doing as an adjunct professor at Georgetown and the U.S. Naval Postgraduate School. So we're very fortunate to have, even just in our two presenters, as well as reflected in the book, folks that are coming at these issues from both sides, in some respects, the health side and the security and stability side. And we hope to tease out some of those insights. As many of you know who've come to this series, we're really keen to understand both the kind of cause and effect, or cause and response, in terms of health connections to fragility and stability questions in a number of countries, a number of regional settings. We've had series that tried to better understand some of the causal connections between instability and health, and particularly population and demographic dynamics. But we're also wanting to look at, on the other side of the equation, so to speak, what some of the health responses can be, and how those interventions can be part of the solution in terms of supporting governance, in terms of supporting capacity, going against corruption, increasing capacity of both state and non-state entities to both provide health and shore up stability. So we're looking forward to hearing some of the insights gleaned from the cases in the book. I'll turn it over to Ross and look forward to an excellent discussion. I think the gentlemen have both said that if you have points of clarification and questions that you'd like to ask as we go through the presentation, please do that. We'll save the real in-depth discussion for the end.
Thanks. Thanks very much. First of all, it's a pleasure to be here, and if you can't hear me, say something and I'll sit down or get close to the mic. Secondly, before I start, we brought over about as many books as we could carry. They were pretty heavy, but we didn't expect as many of you to be here as they're here. But so if you want a book and you didn't get one, if you give us a card and tell us, we'll try to be sure that more of those are made available. First of all, it's a great pleasure for me personally to be here. I've actually come and listened to some of these sessions and have always found them very useful for myself in our career. And secondly, this work is done under the Center for Domestic International Health Security at RAND, which actually began as a global health kind of initiative and quickly morphed into that after 9/11 because we had some initiatives that we had underway. And in actual fact, one of these is the kind of the beginning thought process for this volume. And we labeled that Health as Foreign Policy. And before 9/11, our work indicated to us, and the person who provided the funding for this was concerned that the opinion of the world about America was lessening, and he thought that something needed to be done about that. And he was interested in looking at other ways that got to the social and economic and other kinds of criteria that improved the way people thought about themselves and about the United States as a mechanism that we could think about in foreign policy. I think that's become a little bit more accepted in recent years, but as part of that effort, we decided that one thing that we would like to do is look at this issue of health in the nation-building process. And I'm going to claim rightfully that the idea was not altogether original because Seth and Ambassador Dobbins had looked at health and nation-building the idea of development and nation building as a whole without looking at the health component specifically. So we want to hone in on the health component. And the other book provides a lot of other insight that you might find useful that we probably won't go through today. Finally, what I'd like to say is that it's important, I think, to look at this work in an overall context. And as it was indicated, it grows out of our overall work in the center. And also a specific project that I would mention, and that's our work on Palestine, where we've done a lot of work on how to establish a successful Palestinian state if the condition of peace between the two parties came about. It seemed to us that a lot of work and a lot of discussion had been gone on to about how to negotiate peace, but very little had been looked at about what you wanted to do after there was a peace treaty. And so we looked at this, and I recommend that work to you partly because it integrates all of these various sectors together in one specific, very difficult area. Whether it's health, education, security, water, all of these things, economic development, are looked at as an integrated whole, and there's also quite an innovative infrastructure piece to that, too. Well, having said that, let me turn to what we want to talk about today, and that is nation building and specifically healthcare. So we wanted to look at health and nation building, and we, of course, we had to try to think about what that meant, and as I said, we had the earlier work. But in essence, what we're trying to look at is a transition from war, or in this case, U.S. deployments, to economic and social stability. And obviously that includes a lot of factors. Some are listed right there: health, security, economics, governance, education, basic infrastructure. But it's our feeling and our assumption that actually all is involved. And in the transition to stability, and in the book we also speak about a transition to democracy, which we can talk more about. Well, our goals are very simple. We wanted to look at past efforts, in this case 7 distinct efforts after U.S. nation-building operations, and look specifically at the healthcare system and what were the effects of the nation-building and health's effects on that process in these 7 countries. And we tried to pick countries, 7 in total, across the spectrum that we felt was important. So you have Germany and Japan after World War II, which are commonly thought to be successful. Somalia, Haiti, Kosovo, and then the more recent examples of Afghanistan and Iraq, which I'm sure many in this room, if not all of you, are working on in some way or another. And we wanted, secondly, to try to figure out what the most important lessons we could learn from that were, so that ultimately, as RAND does in all exercises, try to think of what policy recommendations we might want to make that could be available to those people like yourselves who look at this stuff on a daily basis. Well, what did we do? We first defined success. It's important that you do that. We looked at pro-conflict Reconstruction efforts, identified common themes, and then provided lessons learned. So the first thing we want to do if you're going to talk about successful development or successful nation building is, what does that mean? And we actually adopted quite a simple measure that success from our perspective meant an improvement in the health status of the population. And we picked a few common measures for that pretty much are available statistically. life expectancy, infant mortality, birth and death rates, malnutrition, infectious disease rates, things that we could get a little bit of a handle on. But in addition to that, we felt to be successful, you had to create a sustainable, and I underline the word sustainable, into the future, healthcare system and public health system. Otherwise, you haven't really met our criteria for success. You can quibble or add to this, but that's what we started with. And this picture here pretty much summarizes all that we would say in one slide, or we try to. And in essence, what it says is something very simple, that to be successful in nation building, you have to be successful or take into account all of the aspects of nation building, and they all influence each other. In this case, we're particularly interested in healthcare, but health affects governance, education, economic stability, security, basic infrastructure, and vice versa. So you have to think of this problem as an overall whole, in our opinion. You can't just concentrate on one aspect and expect to understand the problem. So what were the key findings that we arrived at? And the first is that nation-building efforts cannot be successful unless enough attention is paid to health. And if you want a more articulate kind of presentation of this than I can give, I recommend Amartya Sen on development to you, where he makes this point really quite, not in a nation-building context, but he makes this as relates to development quite articulately. Secondly, second main conclusion is successful health reconstruction requires both planning and coordination and infrastructure and resources. And as we go through this, and Seth's going to go through the individual cases in some detail, we'll try to pull out why that's true. Health can have significant independent effects itself on various sectors, whether it's sanitation, water, education, economic development. And security is essential to all reconstruction. If you don't have security, nothing else will succeed. Or we like to say security trumps all else. And finally, the health sector reform should be sustainable if it's going to, in fact, be successful. Poor coordination can have serious consequences, and I know that's something that AID deals with every day as you try to herd those cats that are your NGOs or your contractors. And I'd like to come back and at the end talk a bit about that, because in my own personal experience that became an important criteria, and I think the term these days is harmonization. To me, that is one of the aspects that we would like to look more seriously at than we've had to this point. Restoration of health. Okay, so health can have independent effects, quite obviously, in lots of different ways. Health clearly affects economic development through its effects on increased productivity and reduced absenteeism or days worked. And health can be a key social stability determinant also. It's very important to understand that the environment around which countries exist, societies exist, the rule of law is established, is critically dependent on healthcare. It's not by accident that revolutionaries like Mao Zedong or even Hamas and people like that have always honed in on healthcare as one area they promoted to promote their own agenda. They understood these lessons pretty well. Health can support security by reducing the support for criminal and insurgent groups, and restoration of health-related infrastructure is essential to the successful nation-building operation. But in turn, other things affect health also. And without basic infrastructure such as electricity or water, you're not going to have very successful efforts in healthcare improvement in health status. Without good governance, it's hard to imagine you can establish the health infrastructure and the public health services necessary to deliver what needs to be done. And without adequate levels of education, the kinds of health manpower you need, or even the involvement of mothers in particular and children to improve health status is most difficult. Security, as I said before, is essential. I don't think I probably need to say much more about this, but in Iraq recently, it's very disturbing that, in fact, the insurgents have targeted health professionals, physicians and hospitals directly, because they understood the relationship between health and stability in the population, and that was a disruptive force. I find that really quite disturbing. And also, if you don't have the equipment, other things necessary, which are very hard to get, and the lack of security, it becomes an important issue. Poor conditions have had serious consequences. Excuse me, poor coordination has had serious consequences. Again, I'll skip through this quickly, but as I said earlier, lacking coordination among various actors I think you actually can set up processes within countries and various power groups within countries that actually make it harder to achieve sustained development in the long run, because you create the kinds of power bases that each individual group looks at its own area and doesn't sustain or promote the overall best interest of the country. Finally, as a kind of an introduction, I think it's important to realize that thinking about nation building, there are a number of phases that one ought to think about it in. And one can quibble that this is not the right way to slice this pie, but certainly there's a pre-conflict phase. There's the conflict, whatever that means, and where you draw these lines is kind of hard to determine. Then there's the immediate post-conflict, which is where most NGOs, and actually I think the world in general, is very good at responding. Whether it's a tsunami or whatever, people rush in, they take care of it. There's lots of groups that are running that. And then there's what I'm going to call the reconstruction. That's after the picture taking dies down and the hard work really begins. Finally, we would make a distinction between reconstruction and consolidation, or when you've reached a longer run period. In those efforts that are successful, there's a tipping point that we'll try to define a bit, then moves on to success, as would be the case in, say, Japan. In other countries, it's flat, and you never reach that tipping point. In fact, you've had a deterioration during the conflict, and as in Somalia and Afghanistan, you're going to see that you never quite get to the improvement level. You never quite succeeded. Well, with that, quickly, these are some dimensions of successful health reconstruction, and I'll let you read those because I think that they include infrastructure, coordination, planning, and some detail. With that, what I'd like to do now is turn the podium over to Seth Jones. I did this. I'd like to turn this over to Seth Jones. As I said, we did health and nation building a long time ago, and that effort began with an effort in England to bring together people from the defense community, the foreign policy community, and the health community. At very high levels, included the head of WHO, a couple of ex-ministers of health, the ex-foreign minister of Britain, people from our State Department and Defense Department. And what was interesting about that meeting is that all came across saying we never talked to each other. And the perspective shared was quite important. So when we started looking at this, I'm glad that Seth and I have had a chance to both be here. We represent quite a large team, as you can see, with a lot of interdisciplinary degrees. But Seth is one of the experts on nation building and security at RAND. He's had a tremendous amount of experience, and I'll let him tell you a little bit more about himself. But right now, he's doing an awful lot of work in Afghanistan in particular. And I think it's probably fair to say that on counterinsurgency in Afghanistan, he's one of at least the United States experts.
Thanks, Ross. What I want to do here is move through some of the cases we looked at. Ross talked briefly about some of the broader lessons, issues like coordination, issues like the independent impact of health on other aspects of nation building, and in turn, the impact of several other sectors, including and in particular security on health, and he talked about several other things as well, the importance of sustainability and tipping points. What I'm going to do is take that broad discussion and briefly go through a couple of cases. But before I do that, what we wanted to do was we looked at, as Ross said earlier, a number of cases going back really to World War II. Part of the reason we wanted to look at Germany and Japan was because they actually offered interesting comparisons. I think when we actually looked at health, the sort of dependent variable, and looked at some of the health outcomes, these cases were actually quite successful. On the other hand, they do show that both the German and Japanese cases, we started in 1945 with Reconstruction efforts in very developed countries. So we see the distinction between starting from countries that already have a leg up on basic indicators, high levels at that time of economic indicators, levels of governance, human capital. And we can see that it actually made an impact and made it easier in many cases to do nation building work, including in the health sector. So what we did here was we broke the we broke these cases, we looked at them across two axes. I'm going to use this microphone instead. A little awkward. If you can't hear me, just if I'm talking too close, make sure you let me know. So we looked at two aspects here. And if you want to ask questions, I'm not going to go into detail now, but we did a little bit of a statistical analysis. We looked at a number of variables that we called infrastructure, which included both conditions at the beginning of conflict, but also just sort of basic infrastructure levels at the beginning of conflict as well. And we also looked at efforts that we called coordination and planning, which were really controllable factors by outsiders, including the U.S. government and other entities, efforts that they produced. So in other words, we found here that ultimate success was both a function of factors that are controllable by outsiders, as well as the conditions that were in place when the nation-building phase began. So it's important to understand that both sorts of factors are impacting the outcome here. So we divided these into, or they sort of came out into three different groupings. The first one was included both Germany and Japan, and these were very successful along the lines that we looked at earlier. They had increases in basic health outcomes, infectious disease rates, life expectancy, and they tended to correlate with high levels of coordination and planning on one axis and infrastructure, including levels of human capital, on the other. And we had a second grouping that was that included both Kosovo and Iraq, and we consider these roughly mixed cases, where their outcome was where you had either sort of status quo levels. You didn't see a lot of improvement, but you didn't see deterioration in basic health outcomes. And they tended to have varying levels of, in this case, both lower levels of coordination and planning, though higher levels of infrastructure, and then a series of countries that we considered basic failures on the health end, which had deterioration in most cases in basic health outcome measures like life expectancy rates, et cetera. And those would be Afghanistan, Somalia, and Haiti. We actually had nothing that fit into that bottom right quadrant. We hypothesized that something like the health effort in East Timor might have sort of fit into that category, where there was substantial coordination and planning, partly because it was such a small country. But the levels of infrastructure was so poor when the Australian and UN began in 1999 that hypothesized that might fit in there, although we didn't look at the case. So these cases come into sort of three different quadrants. Now, I want to just highlight two things about this. First, the Iraq and Afghan cases were a lot less certain about. I mean, one of the things that makes it easier to look at Germany and Japan is so much time has elapsed. So we can be pretty confident that we've got enough data to make good conclusions. Iraq and Afghanistan, not a lot of time has gone by, so we're a little hesitant on making definite conclusions on those cases. So those are a bit more tenuous. So I'm going to go through these pretty quickly. But feel free, when we get to the discussion phase, we can actually return to some of them, just because we're not going to have a lot of time to go through them. I want to start with Japan. What I want to do is highlight a case or two in each of these groupings, just to show you what some of the lessons were. So I want to start with Japan, and I want to begin, and as Ross noted, the phases as you move from the conflict phase into the immediate post-conflict phase, or the relief effort. That what's important at that phase in particular, when the Reconstruction or nation building begins, is the context that country operates, the initial conditions that exist in that country. So in the Japanese case, it was actually quite clear that Japan had, including in Asia, very high levels of human capital. Its healthcare system was based on the German model, but was quite competent, quite good. That the U.S. administrator provided, in that case, strong leadership, and that the United States one of the things that we actually looked at in the establishment of security, which we thought was a key component of health, there was some correlation between the level of resources put in terms of troops and police and outcomes in terms of security. In the Japanese case, we had, partly because this was World War II, large numbers of troops in the country, which helped stabilize, and that offered, in our argument, conditions that were useful or beneficial for health, because the security environment in Japan after the war was pretty benign. There were no U.S. deaths caused by hostile activity in Japan. So that actually made the health effort much easier. So at that time zero, what we saw was, despite earlier efforts of high levels of human capital and high levels of infrastructure, what you saw was a pretty devastated country. There was malnutrition. The U.S. had conducted, as we all know, very significant strategic bombing of Japanese cities, including dropping atomic bombs on Hiroshima and Nagasaki. That impacted lots of aspects of health, including vaccination programs. So the conditions were actually quite poor, but at least in this case, Japan had, as I noted in the earlier slide, a pretty good baseline to begin with. You can see, actually, this highlights the sort of maroon line here, notes the, on the left side, the number of hospitals, clinics, general clinics, hospital beds in 1940, so really before the war in Asia began, the U.S. was involved, and doctors and nurses as well, and you see a huge decline in all areas. I mean, a huge jump, and even in hospital beds, you see a decline of 204,000 all the way down to under 50,000 by 1945. So, in fact, if you go through the U.S. strategic bombing literature, we actually, for better or worse, probably for worse, literally targeted hospitals as well. I mean, it's pretty clear now in the data that's been released. By 1952, so 7 years after Reconstruction efforts in Japan, all of these aspects, basic aspects, improved. Life expectancy improved, and we correlated that with some of the disease prevention conditions that the United States helped put in place in Japan, public education programs that increased public awareness, school lunch program that Colonel Sams and U.S. administrators put in place in Japanese school systems. This is sort of to introduce powdered milk, which had actually a profound impact on health, at least of school children. And they did a number of other things like reorganize hospitals. So part of what we wanted to look at, and actually if you look at the data here, you see a pretty notable decline in most of the basic indicators like infant mortality, the death rate, and then an increase in ones like life expectancy. So quantitatively, we also saw pretty clear correlations between the inputs that were put in and what you were getting on the outputs. So we were able to then map a pretty clear success effort there. I mean, quantitatively, and we tried to correlate that with the inputs and the initial conditions that were in place. So one of the things that we noted, too, was that health can have an impact, and a profound impact in some cases, on broader governance and democratization efforts. Second, that meeting basic health needs, and we saw this in particular with the school lunch program, which was actually quite interesting, helped win what we call hearts and minds, or popular support. It created fairly high levels, something that was very tangible to the Japanese public, and was able to trigger fairly positive implications towards the U.S. authority in Japan. And then, in this case, the establishment of security by U.S. and also Japanese forces created conditions where it was just easier to rebuild. There was no insurgency. There was, levels of crime were pretty low. So in that case, this is why the Japanese case, though it happened back in the 1940s, was actually quite important, because we did see that the impact of health can have a positive impact on both health and then broader nation-building outcomes. So it was a good one to look at. We also looked at cases of mixed success, and so I'm going to quickly go through the Iraq. I'm going to assume that most people have followed this a little closer than, I mean, partly mixed because it's not entirely clear how this is going to, the outcomes here, we were pretty tentative on long-term trends here just because there's not a lot of good data. I mean, I think you'd need a couple more years to be able to come to some firm conclusion. But we know that over the course of the 1990s, that health conditions had actually deteriorated partly because of the economic sanctions that had been leveled. But if you look at sort of basic, basic indicators, basic indicators actually we looked at a number of these, health, sanitation, water, infrastructure. Most of them had deteriorated pretty significantly over the course of the 1990s. So by the time that Reconstruction efforts began, the health situation was certainly much worse than it was about a decade before. So water services in Iraq before the conflict, we looked, for example, in a couple of major provinces and noted a decline once the post-conflict era began. A decline in many of these categories. Malnutrition remains a problem. You see actually decline throughout the latter half of the 1990s. It's come up a little bit in some cases, but a lot of the indications have not improved significantly. So by 2005, we tried to get a sense, because we finished this report in 2005, we felt that a couple of things were making it difficult in the health sector. One of them was the lack of security, and I'll show you what I mean by that in a second, and I'll show a correlation. Hospitals and clinics, in many cases, still in poor condition, and security in particular had a pretty significant impact on health reconstruction efforts. Now, this actually maps, this correlates, it's an interesting correlation between water services and security. And what we've done here on one axis is look at the number of attacks, and those little dots represent each of the 18 governorates in Iraq. So we looked at the attacks on one axis, and we looked at the change in hours of water service on the other axis. And we saw a pretty clear correlation that the higher the number of attacks in provinces, the lower the worse the percentage change in hours of water service. So we saw a deterioration in many situations. I mean, this makes intuitive sense that in provinces or governorates where there were higher numbers of insurgent attacks, it actually led to had a very clear impact in water services that were that reached the population or didn't reach the population. So sort of an interesting. You could draw a regression line there, but you can see a pretty clear correlation between those factors, which we thought was sort of interesting. So one of the clear cases here, but this would, I think there are a number of people in this room that have worked in the African context, and a lot of these, as we'll see with Somalia, are true there, that poor security really can have a quantitative, you can almost measure the impact on health. And actually the reverse is also true. There's an interesting article, if you haven't read it, that's in, I think it's the journal Military Review by General Peter, I'm going to mispronounce his last name, Corelli. He was the head of the general in charge of the 4th Infantry Division in Baghdad. He makes an argument that in some of the areas they were operating in, like Sadr City, for example, in his view, and according to his some of the stuff ends up being classified, the actual numbers, but there was a clear correlation between areas where health conditions were poor and support for insurgents. So in areas where people were not getting basic health, immunization, water services, malnutrition was poor, that in their argument there was a clear correlation between support for insurgents. So that's why I say there were these arrows go in both directions here. So our research actually showed that was the case, that poor security can contribute to poor health efforts, but poor health conditions can also impact security. It can increase support for spoilers and other insurgents. And a couple of other brief lessons that are unpacked a little more substantively in the book, but I'm going to sort of move on to our other cases. I've been on the ground quite a bit in Afghanistan, so and then we'll also look at Somalia. And these are cases where we also argued that in particular they were failed efforts and health outcomes deteriorated in in both of these cases. Afghanistan a little also tenuous because we're still only about 5 years or so into that phase. Starting briefly with Somalia, what we had some people actually, and we pulled some of this data from people who were involved in the Somali operations. In fact, one of our reviewers was the chief envoy to Somalia during the nation-building effort. And of course, as you know, those initial conditions had a profound impact, we would argue, on the health sector and health reconstruction efforts and nation-building more broadly. That poor governance, poor economic conditions, a leadership vacuum did have a significant impact on how much work and health work could be done in those countries. So lack of security, political uncertainty certainly hampered humanitarian efforts, including longer-term health efforts. So those initial conditions mattered quite a bit. Also, look at education level. 75% of the country was completely illiterate. So there were very poor, began with very poor initial conditions. So by 1991, when the effort that we looked at really began, again, life expectancy among the lowest in the world, widespread famine, malnutrition, and high infectious disease rates, poor sanitation, sewage, waste disposal, landmines. There was a pretty, this is also sort of an interesting graph, too, in that over the last couple of decades, Somalia's been highly dependent on external aid in general, too. This is this sort of rentier effect. Couple of years after, so we sort of closed this by 1995 when the U.S. had generally withdrawn most of its effort on the ground there. Most of these basic indicators had actually not improved. Infectious disease, maternal infant mortality rates had not improved. In some cases, actually gone down. Malnutrition, still chronic. Landmine injuries were still significant. Expansion of UN mission impeded progress in general. But the lack of security also had a profound impact on sort of basic health services. And one of the things we also, which Ross didn't mention earlier, but one of the things we also found interesting was that time actually was an important variable in some of these. And so the fact that the U.S. pulled most of its resources out, as did other international entities, by 1994 and 1995, also had a profound impact. And the same thing, and we're not going to go through it here, same thing was the case in Haiti. So where there's not a long-term sustained effort to do these sorts of activity, it's hard, especially in the health sector, to make significant progress in health and to have that then impact other areas. So time was a particularly negative factor in both Somalia and Haiti, where international actors, including the U.S., just did not stick around for very long. And you can see that there's a slight dip in life expectancy, but the trends continued in the general same direction. So some of the key lessons from the Somalia case were the importance of security, the fact that governance is actually quite important in health efforts, and a number of other things. The importance of planning, and another thing that's sort of interesting here was. This last bullet points to, and I'll read it, smaller projects at the local or regional levels may be more successful in some of these failed states. They can be very tangible. And again, we learned this, I think, in Japan as well. There were clear cases where smaller projects that were targeted toward the specific population that were very clear and apparent to that local population can sometimes be profoundly successful and can have broader impacts on hearts and minds, for example, as that milk program in Japan identified as well. Afghanistan, again, most of you are well aware, it has a long history of very poor initial conditions. One of the most underdeveloped countries. It still feels that way when you're in Kabul, Kandahar, Herat. Even today, you do not get electricity 24 hours a day, even in the capital. In fact, my hotel 2 or 3 months ago had electricity for about 12 hours or 10 hours in the middle of the day, and this was a major hotel in Kabul. So if I don't get it, then certainly the population's not getting it. Continued violence certainly had a major impact, the Soviet wars and the various insurgencies over the course of the 1990s. By the time that Reconstruction efforts began in December 2001, you had most of these factors, were pretty, it was a pretty, the bar was pretty low in Afghanistan. There's a lot of long-term work that needed to be done. And these initial conditions are very important to understand because it gives us a sense of expectations. It's important not to set too high expectations for some of these cases, I would argue, because they start from such low baselines. So, we've noted life expectancy, notably different in Afghanistan than in any of the countries, even in the region. I note its neighbors, Pakistan, Iran, Uzbekistan, just to use a couple of examples, significantly different. Infant mortality rates, also a huge gap between Afghanistan and its neighbors, Pakistan, Iran, just to use Uzbekistan. We also looked at all of its neighbors, but you can see it begins from a very different baseline, even from countries on its border. Violence levels over the course of the, since U.S. forces have been there and health reconstruction efforts have gone on, have had, I would argue, very profound impact. This actually goes through May of '06, so just recently. You can see that the levels of violence have been spiking, but by 2006 have reached the highest levels. I mean, they've quadrupled since early 2002. That in many areas, especially in the south and east, have had a profound impact. In fact, if Ross mentioned this correlation earlier between security and health, and we found it's probably useful to note that that this correlation is particularly acute in sections of countries. So in other words, you can't make this argument across a country. So when I say violence in Afghanistan has impeded health efforts, we're really talking about the south and east of the country, and not necessarily the whole country, as northern provinces like up where Mazar-e-Sharif is, for example, or out west in Herat. We're talking about the southern provinces like Helmand and Kandahar, and some of the eastern provinces like Paktia and Paktika. So it's it may be possible to do this in some sections rather than others, or the impact. So some of the key lessons that we learned, again, is this correlation between security and health on both ends that we've seen actually, and General Eikenberry in Afghanistan has done this as well, correlated the poor health conditions in provinces like Helmand with support for insurgents. So he's noted that he's made an interesting, if you can get a hold of this, I think it's actually, what I've seen was a classified one, at least the numbers were again, but there's an interesting correlation between areas where there is strongest support for insurgents. Provinces like Helmand have very, very low levels of health. And so there is some concern that when health conditions are so low, the concern is that people become unhappy with the level of governance and they turn to other actors, in this case the Taliban or Hekmachar's Hague organization. This is exactly what, as Ross noted earlier, we've seen in places like Palestinian territory, or even in Lebanon with groups like Hezbollah and Hamas, that poor health conditions can impact security. And this issue, as I noted earlier, of time in Afghanistan, so long-term expectations actually ends up being quite important. So Ross outlined up front some of the lessons, the broad lessons that we talked about, and I'm not going to go through them in any detail, and he talked about issues like the tipping point, but I just want to highlight some of them here. I could just skip to the end. The key findings, really, health in most of these cases can have an important independent effect. In some cases, it can have a negative impact on hearts and minds. In some cases, a positive one we found with Japan. It can also provide groundwork for democracy in some cases. Health success requires, in our view, a couple of things. high levels of planning and coordination. Where you don't have that, as we saw with Somalia, actually it leads to negative health outcomes. Levels of infrastructure and resources, so where initial conditions are low, that can have an impact, as we saw with Somalia and Afghanistan, on the overall outcome. Now, that doesn't mean you shouldn't be involved in, obviously, in health efforts in these countries, but it's important to note that the bar gets set quite differently for those countries compared to Germany, Japan. It was nice to be able to actually see that clearly. Again, health linked to success in other sectors, sanitation, water, education. We found correlations in Iraq, Kosovo, and Afghanistan too. And then this importance of sustainability, especially in countries where the initial conditions are so low. And then, of course, finally ending with this importance of security. Again, both going in both directions. The importance of security conditions for working on health, and the importance for security of health in those areas. So I think with that, let's conclude, and I don't know how you want to open this up to questions.
Absolutely. I think that's exactly what we'll do. There are a number of angles we can take. I'll ask that folks let us know who they are before posing their question. I'll also just note for those who don't have the book in front of them, that Kosovo and Haiti were the other two chapters in particular, as Seth mentioned, that are also in the book. So who would like to open up the discussion? We have microphones that we ask that you use. If we could start down here so that the folks on the videotape can hear. Ken, if you could come down here to the middle. Then right all the way up front. Here. Oh, yeah, there we go. Thanks.
Thank you. Thank you. My name is Gary Cook. I'm a health advisor in the Asia Near East Bureau of USAID. And like many people in the room, have been associated with the health programs in Afghanistan and Iraq from the very beginning. I've traveled out there multiple times, as recently as in both countries within the last 2 months. And I think, when I hear this, when I first read the report, I feel this great kind of mixed feelings about it. I, like everybody in this room, probably feel, really applaud the idea of highlighting the importance of health in development and nation building. We really are passionate about health, most of us in this room anyway, so this really strengthens our case and our feeling of self-worth. At the same time, I have a couple of concerns. And the first one is specifically for Afghanistan, which I've been very closely associated with. I find it difficult to see how you can, in the text and in your words here, say that it's too soon to tell, which is what I certainly agree. Starting out at such a low point as it was, starting from dust and building up to what it is today, I think it's on a good trajectory towards success. So I guess my point is I don't see how you can say it's too soon to tell and at the same time show it up in a graph as a failure. I think it's far too soon to be able to do that. And think, in fact, labeling it as a favor jeopardizes strong leadership and support from Congress for continued funding. Because that word kind of gets around, it's a failure. So, okay, why would we invest more? The second point is, I think if you go into all the trouble of having the premise that you have put out here, which I think we all agree with, that health is important, it's very incumbent on you for your case studies to be researched thoroughly, accurately, and completely. And whereas in the Afghanistan one, I do see quotations, documents, references to DOD work, HHS work, hardly anything about USAID. And the USAID activities in Afghanistan are probably 85–90% of what's going on. In fact, the chart that's there that shows the investments in all the different sectors shows about $100 million for health in 2004, and that's about exactly what USAID put in. So there's very little talk about the assistance there. I think the successes that are going on there, in fact, are tremendous. The Minister of Health is fond of saying they've gone from having 7% coverage of the basic package of health services right after the Taliban fell to almost 80%, and that's with USAID, World Bank, and European Community Assistance. So I know I'm going on too long, but those are kind of two things that I wanted to put on the table.
You're giving us an example of that coordination challenge. Right, we have a question over here. Well, why don't we yeah, let's collect a couple, though, because we're going to have a lot, and that way that you give a kind of basket to respond to.
Thank you. That was very interesting. My name is Karen Foreit. I'm with Constella Futures. I'd like to talk a little about some correlations and causality, as anybody who has taken a statistics course is really a touchy area. And I'm reflecting back on my experience in Korea, which is an interesting case analogous to Japan, and in Peru during the Shining Path. The thing that concerns me is the correlation between poor health efforts and poor health status and support for insurgency. To draw a correlation, causality that says poor health leads to support for destabilizing elements, there's often a third ingredient in that traditionally ignored or suppressed areas of a country or ethnic groups are deprived deliberately by governments of services because they don't belong to the ruling party, the ruling clique, whatever, and so that the support for the insurgency may not have anything to do necessarily with the poor health conditions, but rather the poor health conditions and the support or the opposition, let's not call it even support for insurgency, but opposition to the established power may also come from a deliberate targeting away from those areas or groups by the status quo.
A couple more, and then we'll. Yeah, Jeff up here, Ken right back here. Sorry.
I didn't have a chance. Jeff Spieler from USAID. I didn't have a chance to look at the book. So, as you pointed out in the introduction, that a lot of the data is in the book, and of course, in a presentation, you can't take the time to present all the data. And I'm always interested in the data that supports statements. And when I looked at that table, there's a lot of conclusions are.
Which table?
Pardon? When I look, I was going to say a lot of conclusions are almost self-evident, and one doesn't search for too much data when it fulfills your expectation. When the statements fulfill the expectation. But when I looked at the table, it says poor security hinders reconstruction, and you have percent change in the hours of water service in relationship to numbers of attacks. Well, one would certainly think that when you have a huge number of attacks, you'll have lower water service. But even in the places where there were 0 attacks, there was very low water service. And if I were to draw a line of best fit, I'd almost get curvilinear there. But no attacks and no water service. It's certainly the lack of water service is unrelated to the number of attacks. And when there is low water service and a lot of attacks, I wonder if is it the attacks that's causing it? So the cause and effect, sort of what Karen was asking for. Why is it there? Why is there poor water service when there's a lot of attacks, and why is there poor water service when there are no attacks?
Ross would like to respond, then we'll come to a second round.
I'm going to let, I think most of these are Seth responses, but I'll respond to them.
These are actually these were good questions. I'll answer them in sort of the 3 segments that they came in, and then Ross, if you want to add anything to what I'm saying. The first one really was on Afghanistan. Now, as I noted earlier, when I say too soon to tell, I mean, we looked at what we call outcome measures, so some basic data that we looked for. In fact, the lead author of that chapter, who is not here with us, was the full disclosure, wife of our former ambassador to Afghanistan and current ambassador to Iraq. But she was in the country numerous times, partly researching this as well. Now, her, interesting because he actually read through this chapter before it came out as well. Zalmay read it before it came out as well. That's full disclosure.
Doesn't mean he agreed with it.
That's true. So a couple of things there. Just on your point about too certain to tell and failure, I mean, what we looked at outcome measures, did not see significant increases, or in many cases we saw decreases in key outcome measures. So what we said is, okay, based on the data we had at the time, that we considered them to have not increased in the areas where we were. This is how we mapped cases. If they decreased, or in some cases stayed the same, then we coded them as failed. But again, as we make clear in the book, it's too early to come to any sort of definitive conclusion. So based on the evidence we had available at the time, which frankly it's hard to come to, I mean, you can't come to a final conclusion, but based on the evidence we had at the time, that's where the our evidence showed that direction. But I actually think, in terms of this issue of Congress, I mean, I would say that the fact that, and I'll use the security analogy, the security situation has notably declined in areas of the South and East, that in going to organizations like Congress, I think this actually shows a greater need to place more resources to deal with these issues. So I would actually say, I would come to the opposite conclusion, which is if in areas like health or security that our basic outcomes are not improving, or in some cases declining, then that just means that we have to redouble efforts. So I would come to a sort of different conclusion. And then on the efforts of USAID, I mean, Cheryl Bernard was our expert on that. So and was in country a number of times. So I'm going to say, if I mean, I can sort of pass this along to her, and but I don't pretend to be. I mean, she was the primary author of the chapter. As I said, I've been there a number of times, but we'll pass that one off to Cheryl. Okay. In fact, I'll note that. Then the second question on correlations and causality. Yeah, that's actually why I did not use the term causality in most of these cases. Because it actually, when you unpack them, it gets very difficult, as most people who are social scientists in the room know, that even when we have correlations, to try and unpack causality here. So what we felt in many of these cases, we had enough evidence to show that there was some correlation. When you look at what was causing this correlation, it turns out in areas of poor. You noted earlier that in areas where there are low levels of health, we see greater support for insurgents. So that actually, you're right, that may be caused by several things. That may be caused by a deliberate effort among the government to deny these groups. But it may actually be caused, and I think the Afghan case would be, it may actually be caused by other things like poor governance in areas which may be controlled by tribal leaders or militia groups, and where the government actually has little clear control. So poor governance in those areas may actually be contributing to that as well. Where, I mean, in some of these states, we have a very weak or non-existent government outside the capital region. So I think the issue is that I would say that health certainly contributes, the absence of health, I would argue, and I think there is clear evidence that in some of these cases, and I think there's sufficient evidence in areas like Helmand, for example, to make an argument that the lack of health and several other key factors has contributed to a change. There's a very interesting paper that's just been put out by the director of intelligence, the NDS director in Afghanistan, who actually makes this argument that in the South and East, his view is that poor health and governance conditions has contributed to a rise in support. So I think there is some evidence. There's certainly on the Afghan side some belief that this may be true. And then finally on Iraq and water, I mean, the issue what we were looking at here was change in the hours of water service. So again, this issue of correlation and causation. I mean, I think we could certainly say that, or I would be comfortable saying that that the security situation was probably one of several factors that may have contributed to the decline in water source, but there certainly were probably, as in any, when you actually, if you were to run a regression, just to use that example, you would probably find there were several variables. But that, and we actually tried something along those lines in all these cases, and it just turned out to be extraordinarily difficult to get the, reliable data for most of these cases that you could do something like that with, with some. But we actually ran some first, and we had no confidence in the results. The data wasn't good enough, so we had to run with these sort of correlations.
Let me add a couple points. I did some research here. So there are 3 pages out of 20 with references to AID. I was glad at least there were some there. Otherwise, I was going to be embarrassed. Actually, more of a question than a comment. So at least we didn't totally ignore that, but it doesn't appear that there were any on Afghanistan. So, and as Seth indicated, each kind of section, each country was kind of taken by a different person. In my experience at AID, and I was there for almost 3 years or 2.5 years, we didn't make any effort to publish what we did, and in fact, I think that's a kind of a weakness that AID has in general. Whereas information, sometimes it comes out in some nice internal documents, but in fact, peer-reviewed publications that are routinely available for lots of people, there hasn't been traditionally a culture that promotes that. I think that's kind of too bad, because in my experience, some of the most valuable lessons learned and some of the most intelligent and learned people associated with the efforts, and I'm thinking Eastern Europe in this case, came out of that work, and yet, unless you were involved in it, you really didn't find out about it. So that's kind of a plea to you all on the other side. I agree with everything Lee had said about causation and causality. And actually, many of you are health professionals or deal with health and public health, and our common frustration is that you can't measure very easily what the impact is, because everything's affecting everything else. And I've always wanted RAND to sit back, and because we got some people that I'm an economist by training, but I haven't done real economics for a long time. But we got people that can do all this kind of stuff. But I really thought that what the world needs is a model that actually tries to tease out all of the effects of health, both on the input and the output side. That'd be a very, very difficult thing to do. But in fact, that's the kind of thing that if we could do it, then this trip up to Congress has a vastly different kinds of discussion, because now instead of saying, well, what can you prove it? And you say, well, not really, but we know it's true. And the congressman says, yeah, we'll come back when you can prove it to me. And I've always thought that that's really something that we really need to do to be successful.
Congress isn't always evidence-based.
Yes, that's right.
I once heard a quote that I will put forward in a non-partial way, because I think many are guilty of this, but it goes like this: in politics, facts are negotiable.
If I could just add one thing that we really found difficult in a number of these cases. I mean, when we went back to Germany and Japan, where there were central statistics offices, for example, right? They had high levels of human capital, and frankly, enough time that that you could compile some of the data. That we were pretty careful, or we were pretty confident that we could get decent data to show, correlations, and in some cases, causation. But when you get to some of these cases, I mean, Afghanistan, Somalia, no strong central government, especially before 2001, no real central statistical agency. It's hard to get good data, period. I mean, when you go through a lot of World Bank data for chunks of Africa, and they're blank. I mean, they don't have good data. I mean, the Afghan case on population, we don't even have a census in that country at this point. So part of this is, trying to do the best with what you have. But I would say this in some of these very low developed. I mean, we found this, and I'm sure you on the ground have a lot more experience than we do on this. But we found it very difficult in some of these cases to get data where we could make very firm, conclusive arguments, just because it's so difficult in some of these cases, and they just don't have particularly good data.
Okay. Have some more questions? Okay, yeah, in the back, Charlie.
Yeah, I'm glad you I'm glad you made the last comment, because you are here in a snake pit of demographers and epidemiologists. But for those of us who have lived in these countries when the conflict occurs, and we know how to count deaths, there are manuals on how to count deaths. USAID has them, CDC has them. I know best the case of Somalia, because I was there with a CDC, USAID, UNICEF team coordinated by Refugee Policy Group. And we use other indicators much more sensitive and much more reliable in looking at the impact of conflict. And there are manuals out there that you could use and to improve on your indicators. The first indicator that you need to use in looking at the health or effect of conflict is daily age-specific crude mortality rate. That is in the manual, the CDC manual. The DART team, the USAID DART team, uses that. The second indicator we looked at is excess mortality, because as you say, in these countries, you don't have regular censuses. But we have many other methods of collecting data in local areas where there's conflict. We use surveys, we use surveillance, we use local community health records. So I would suggest you might consult with Julie Davanzo, who's an excellent demographer at RAND, who probably knows many of these. I'm looking at your chapter on Somalia and your chapter on evaluation. I know something about those two subjects. And in the Somali chapter, I see about 100 references. I don't see the RPG volume of 3 books on the health impact of the intervention in Somalia. It makes the point, if I can generalize, and Howie is here from CDC, I don't know if you remember the study, that the humanitarian intervention caused more excess mortality than it prevented. And we did do 30 by 30 surveys in the affected areas. And then I look at the last chapter on evaluation. And really, I think that USAID has had a lot of experience in evaluation and results frameworks. Yeah, look at the indicators here, and no wonder you can't arrive at much of a conclusion, because the performance matrix is almost a macro one. You might want to use it in Japan and Germany, but not in Somalia, Afghanistan, and Iraq. So I think for those of...
And how much of it can you really say is Reconstruction and its success or failure?
Anybody answer that, or do you want to? Yeah. Well, I mean, first of all, I think a lot of it sort of depends on the case you're looking at. I mean, well, 2 points. One is, I mean, I think in order to do this, we'd have to go through some of the cases specifically to look at how much was actually put in, and what sort of resources were put in, and a number of these outcome measures. So you just mentioned one in particular. What we tried to do is look at these level of resources put in, or sort of inputs, and then a range of the outcome measures. So, I mean, I would say that in a lot of these cases, and to use the Japan case, we felt like the increasing levels in all categories, especially when we could correlate them to some degree with the levels of inputs, that there was probably at least some evidence that there was, that those efforts put in and the scale of them did certainly help. Because I don't think, necessarily they have to, in the Japan case, I don't think that, that trend had to continue necessarily. I mean, it could have gotten worse after the war. Could have stayed the same. It could have improved, and it improved in that particular case, and improved in a number of other areas. So our sense was that that at least the inputs from outsiders like the U.S. probably did contribute to it.
You know, there's if you go back to the United States, if you look at the data about health status or infant mortality, there's a kind of a natural trend up over a long period of time. Even in things like introduction of antibiotics don't really affect it much. There are a few things that had a big impact, but it turns out, at least if I remember the literature correctly, that it's kind of been an overall improvement in the entire social, economic, educational structure. The education of women has a big impact, but of the country. And so you could look at Japan, it seems to me, as an interruption in a long-term trend where you've got, and the issue is how quickly can you get back to what was a rapidly developing country before World War II, obviously. And on the other hand, having spent 7 years in the mountains of Nepal, which is a lot like Afghanistan, to be honest, where I was, 6 days walk the nearest road with nothing really around you, that country hasn't, once you get an hour or so off the road, it hasn't changed much since the last 300, 400 years. And so those trends are likely to continue, even with the interventions in the capital city. That doesn't mean that, with the kinds of work that AID does a lot of, and maternal child care and all the other kinds of public health things, you can't make a marked improvement in those factors, and actually, what I would say, speed up the rate of development or change in healthcare status. And I think that's, if we were trying to be really sensitive about this and trying to really get at those kinds of things, that it's really the difference from the long-term trends that I think you'd want to look at.
Gentleman in the center.
Yeah, my name is Paul Emer. I'm in the Bureau for Global Health at AID, and I hesitate a little bit to jump into this discussion because I'm certainly not an expert in this field, but I did just recently spend, and there's another person in the room here that was with me, we just spent a couple weeks in Haiti. And you didn't talk about Haiti, and I'm actually looking quite forward to reading the Haiti chapter in the book and compare it to what we saw and think about that in relation to our recommendations. We were doing a project evaluation there.
When was this, just out of curiosity?
This was 2 weeks ago. We've been back for 2 weeks. And I just wanted to make a couple comments about the health issue that you talked about and its contribution to winning the hearts and minds and doing good stuff and establishing democratic governance, et cetera, which I very strongly support, and the other thing that you said there about the importance of security, because one of the things that we saw when we were there, and again, I'm certainly not an expert in this, it's the only time I've ridden around in an armored car in my life, I think, and it sounds like if you've spent time in Iraq and Afghanistan, you maybe have done a lot of that. So the issue is in a country like Haiti, security is a difficult problem. And one of the things that we have recommended in our evaluation, or are recommending, and it seems to be going along the lines of what the mission is thinking of, is using health as kind of an entry point and a wedge to come into areas and start building on this idea about the importance of health and winning the hearts and minds. But I guess my problem is tying that into the security problem. Haiti is a dangerous place. Seems like a really dangerous place. And I made this comment when we were debriefing the mission. It's easy for us to sit inside of the mission surrounded by armored cars and walls and say, okay, one of the things we're recommending is that you should go into the hot zones of Haiti and you should use health as a spear point to go into the hot zone and help and then build out from there. It's easy for me to say that. I don't have to do it. The people that are going to have to go in and actually provide those services are putting their lives at risk and at danger. And I'm wondering if you have any recommendations or experience, whether it be in Afghanistan or Iraq or other places, where you can marry together this kind of using health as a wedge, but still being able to protect the workers that we're going to send out there to do this work, because they're putting their lives at risk. And that concerns me a little bit, and I'm not quite. We're going to recommend that this is what should be done and looked at, and I know the mission is going in that direction. But boy, how you do it, I'm not sure, and whether you can tie it to in Haiti MINUSTA or the security support that they're providing, or whether AID doesn't do security stuff. Or whether one of the things that happens that we heard is that what you need to do is go into the community, find some local people in the community that are respected, and have them bring you in and allow you to establish your services and then expand out from there. But anyway, if you can talk a little bit about this connection between health and security, that would be useful.
I'll give you, that's a really good point and a serious challenge. I'll give you one anecdote from my, at least my most recent trip to Afghanistan. I spent a bunch of time on the Afghanistan-Pakistan border in a number of areas, in areas that were probably too dangerous for most anybody to go to. So this issue of health came up with the Combined Joint Special Operations Task Force. And so one of the decisions that was made was they would bring health experts in with the CJSOTF. And so at fire bases like Shkin, they would have, in some cases, they were special forces health experts. You know, they were military soldiers with a health background that would provide in villages near the fire base, provide health to the local populations. Now, so in those cases, you actually have health folks that are embedded in joint special. The problem with that is, or at least one drawback is that you know, we don't have a lot of special forces teams and ODA camps in general, so you may be limited in numbers there. But that actually ended. It was interesting, and I don't mean to sound cynical here in the use of health and gathering information, but it turns out that that when ODA camps in general were able to provide health to villages. So Shkin was one example where I visited, where they provide. I mean, there were no medical services provided to anybody in those villages. But when they, in particular, when they were able to provide health to women and children, there was there tended to be an increase or spike in it led to higher levels of trust in general, which in many cases led to information about where insurgents were, weapons caches in areas. So I would say there tended to be some positive impact on winning trust in those places, and leading to information about insurgents coming into those areas. So it did have I think a benefit on the security side. But in those kind of conditions, you had soldiers that had a health background that were doing it because it was too dangerous for essentially anybody else to do it. So that may be one way to get around that as well.
Yeah, I want to, I guess, a couple of comments. One, I don't know if you talked to General Peake, who actually handled the Haiti stuff right after the Haiti. He was in charge of the U.S. military operations, the healthcare operation there. He's at Project Hope now, so you could probably do that pretty easily, but that might be interesting for you to get his perspective. I used to, and I've had a lot of jobs at RAND, but I used to be in charge of the Military Health Policy Research Center. And it has always struck me that the U.S. military in these operations had an awful lot of capacity to do good things that often sits around doing nothing in areas that, in fact, are protected, that all you got to do is kind of open up the gate. You don't have to open up the whole base, but you could, have one gate come. And the most, one indication of that to me was the third and the fourth largest hospitals in the United States are two ships, the Comfort and the Mercy. They're both 1,000-bed hospitals. I've actually gone through the entire. I can't keep them apart, but they're sister ships. But I've gone through the whole thing, and in fact, they sailed one of these over to the theater during the Iraq War, and it sat off the coast. And eventually, they didn't have a lot of casualties at that time, and they started treating a few of the locals that they brought on, and they did things like build fires on the deck, which kind of upset people. But other than that, it worked out okay. But then they turned around and they sailed the ships home. And what always, and then of course the medicines that they have on these ships are expiring, and I don't know what they did with them. They threw them away, or maybe they put them on planes, flew them back again. But it always seemed to me that had any kind of effort to dock the things and actually let people be treated by military. They were, in these cases, they are military and sometimes civilian people that are on these ships, basically bored. They're not doing anything. That there's a lot of opportunities to use what already exists in a very constructive way. And I actually at one point even proposed that the military ought to set up special units that in fact have this as their job. And if you look into the Air Force, you might find, interestingly enough, that there's been a lot of this kind of effort in Latin and South America, where there's been sharing of information and people take on their own time. It's not even military time. They go down and they take on some humanitarian efforts during whatever vacation time they have. So there's tremendous opportunity to use resources that are already there. And Seth said that the drawback was that there weren't necessarily a lot of units in these kinds of areas. To me, the real big drawback is that the troops leave. And you can do a lot of really good things, because it's really important to remember that what you're talking about in healthcare in lots of these areas, particularly in Afghanistan, is treating cuts, and soap and water and a little bit of bastitration has a huge impact, and mixing an occasional shot of antibiotics in. It's amazing what you can do. But if you can't sustain it and you pick up and you leave, and that's what AID is all about, then you haven't succeeded in the long run. And to me, it's essential to figure out a system program that leads from A to B to C, so that somehow you leave something behind, because I think people might ultimately hold it more against you for leaving after giving them some hope than necessarily just attributing a one-time effort to being something helpful. But Haiti's a very interesting example, and it's devoid of a lot of the politics that we have in Afghanistan and Iraq, and whether it's successful or unsuccessful and all that stuff. But and yet, if we can't succeed in places like Haiti, it's hard to imagine how we can.
Kent Hill?
I'm Kent Hill from the Global Health Bureau at USAID. I want to thank you both very much for coming and sharing some of what's in the book. And I think it's terrific that Rand took this topic on. And I think it's terrific what the basic thesis of the book is, because obviously we completely accept it. I think you're absolutely right. Just skimming through it a little bit, noticing at one point, about two-thirds through, where you make the very strong statement that we've got to understand that success in health is going to be critical if we're going to have success in nation building. That central thesis is worth the book alone. And I'm sure you can understand people are a little sensitive here and there if they don't feel like some of the successes that you might have talked about, or some of your contributors might have talked about, could have given a little bit more attention. I understand that. I was in Afghanistan with Gary when a couple of articles came out which described the efforts in health as a failure, which was tough to take on the day when we were the Minister of Health, and we had just looked at the statistics on how much more coverage there was. So we had seen some examples, despite the problems, that there had been progress. But leaving that aside for a minute, we also visited a clinic where a week before, or 10 days before, a suicide bomber had blown himself up, destroyed the doors of the clinic, killed 5 Afghan militia. They'd managed to get the doors back on. It was right next to a fire base, of all places, and it still occurred. And so you're absolutely right. The connection between success and health and what would be perceived as something that would undermine the cause of the revolutionaries is absolutely right. I also think you're right that we haven't always done as good a job as we might in publicizing and talking about some of the progress that's being made. And I think we're doing better over the last few months and years on this, although we've got a long ways to go. It's complicated that because of the political debate, in that there are people out there who are fearful to talk about a success for fear that it would support a policy they don't agree with. So it gets complicated there. The main point I wanted to make was this, with respect to how you measure success. When they set up the Millennium Challenge Corporation, some of us were very much worried that the only standard for doing foreign assistance would be you would give foreign assistance to the states that are better governed and doing pretty well. And much of the work of USAID and the international development community has to be in fragile situations where there's bad states. And, at the end of the day, if you were really honest about what you're doing, you're trying to make a bad situation a little bit better, or not let it get as bad as it's going to get. And there are lots of cases where we're involved where, frankly, the death and the suffering at the end of our work is going to be huge. And we just have to comfort ourselves or have a realistic expectation or understanding that what we did was we prevented some death and some suffering, but tremendous amount of death and suffering went ahead anyway, and understand that's still a legitimate goal and one we should be proud of and still do that. And the second point about this is I used to be in charge of Europe and Eurasia. And for about 5 or 6 years, our assistance programs in Ukraine looked like an absolute and total failure. And I would have to go up to the Hill, and I would have to explain why we would continue to give money for democracy efforts in Ukraine when all the signs were that there was a bad government, it was getting worse, et cetera, et cetera. We kept fighting, and we had enough support on the Hill, we managed to keep it up. All of a sudden, the Orange Revolution occurs, and we're a spectacular success overnight. As a matter of fact, what happened in the Orange Revolution was the result of 5 or 10 years of very careful work on the ground, beneath the surface, when everything was still going south. And the other thing I think we all have to do in the think tank world and in the USAID world, et cetera, is we've got to get better at explaining to the general public, and at from time to time even to members of Congress, although there's amazing understanding here. We have to get better at explaining the nature of our work. Some of it cannot be measured in months or even years, but sometimes in decades even. And in Africa, sometimes in terms of generations. But we have to be able to explain why what we're doing is important, even if at times the indicators are not going the right direction, but why we have faith in the policies and the interventions we're doing because we believe they're going to work. But that behooves us to do a better job of explaining what we're about.
Now, you said all you said a lot better than I could say it, so I won't try again, except to agree with you. And it's become quite popular, but I actually read it before it became popular. Is this whole book on the tipping point, which makes a lot of great examples. The point that you made, and you know, you got to kind of slug up that hill, and eventually, you know, you get over that, and occasionally. I mean, I could give a few examples out of actually my time at AID, which I'm immensely proud of, and they're very gratifying, simply because in little ways you get to that point and you actually see the thing tip. And so, you know, I really do agree with you, and it's unfortunate that in our society and that wants instant gratification for everything, people just aren't willing to take the time often to understand the complexities and the time it takes.
Yeah, if I could just add 2 points. I think, again, you said it better than I could, but I wanted to highlight the importance, because of what you said, in more at the top levels of government and managing expectations sometimes and timelines when we go into some of these operations, to make it clear that for some areas, like health, and there are some, if you read Frank Fukuyama's book on state building, he makes this point particularly clearly, that there are key areas, key sectors of, like health, in some cases like education, where it's hard to do them quickly. You can't do them quickly. So in those sorts of areas, I think it's very important to manage the sort of expectations, including on Capitol Hill, that you just cannot do these things quickly. And lastly, on this duration issue, I think you're exactly right. In fact, I would actually say that in cases like Ukraine, in cases like Afghanistan, if indicators aren't going in the direction we want, the response has got to be in these important areas, not to jump ship, but to continue working at them to turn them around. I mean, and as I said earlier, I was just recently in Afghanistan on doing security-related work, and I think the indicators there are very clear that the level of security has gone significantly down. But the response can't be that it's time to leave. It has to be to continue to slog through them and find ways to improve it. I would say the same applies to these sorts of situations, whether we're talking about Africa or other, that in those areas that actually should be an impetus to continue pushing.
In Afghanistan, and Seth can make this point better than I have, what's amazing is how well things have gone, because in I think more in the other book than this book, is that the amount of aid per capita or per any measure you want to make that was put into Afghanistan is lower than any of these other cases by a large factor. And one can't help but wonder if there had been even, a level that was on average, how much more successful that the efforts might have been. And that's another factor we haven't talked about here, but there's significant variation within these cases on the amount of effort that we as a country or the world has put into the various cases.
Well, terrific. Gentlemen, I think this is a good place for us to conclude. I want to thank our audience for some provocative and tough questions, and we appreciate that always when people take it seriously and
have actually read the book or something, clearly.
Down to the footnotes and what's in and
right.
what's not. But thank you, gentlemen, both, and we look forward to future dialogue and particularly as you push forward this research. We obviously have a lot of people who want to be a resource for doing that and are a valuable resource. So we look forward to doing this. So please join me in thanking our guests and look forward to